Well, then let's get started. All right, so we're going to go over two articles today. They're both free, so we can get them all done today. First one is titled "On Cervical Zygapophyseal Joint Pain After Whiplash." So those are the joints in the back of the spine. Grab me a spine. So these are going to be your joints that sit in the back of the spine and sort of interlock in this fashion. Okay, and there's where the big injury happens. Because what happens when you get that S curve we talked about is that the joint they sort of like jam. All right, and that's where the ligament injury occurs. So the researcher in this is actually a world famous researcher, Dr. Nikolai Bogduk, and he's an MD PhD out of Australia. And he does, all right, great. And he does some of the best research in the world when it comes to the spine. So we want to look on our assistant here. All right, the joints are in here. All right, can you see that, Mary? These are the joints in here where the
yes.
bones are locked. All right, so that's where the injury occurs, because remember we talked about the S curve. So what happens is the spine gets buckled backwards and then forwards. All right, creates that S curve, and the joint jams. All right, and that's where the ligament injury occurs. And grab one of those models in Dr. Miguel's office there. That's an easy way to show that. But Dr. Bogduk is a very, he's not a user-friendly kind of guy. He's very sort of gruff, chain smokes cigarettes even today, and but he is the best in the world when it comes to this stuff. So this is December 2011 Spine, the #1 orthopedic journal in the world. And Dr. Bogduk says the objective here is to summarize the evidence that implicates the cervical, we'll just call them cervical spinal joints, as a leading source of chronic neck pain after whiplash. Summary of background data. A pathoanatomic basis for neck pain after whiplash has been elusive. However, studies conducted in various disparate disciplines indicate that this is not necessarily the case. There's convergent validity from 1, whiplash postmortem studies, whiplash biomechanical studies, whiplash clinical studies indicating the primary source of chronic whiplash pain is injuries to the cervical spinal joints. Now, the whiplash postmortem studies, those are the best ones. Because what they do is they freeze the specimen and then slice it. And what's fascinating about this is that they find, so what they do is they'll X-ray and MRI and do CAT scans to the samples from the cadavers, and then they do an autopsy, and they slice the things up really finely, and they see what kind of injuries are there, and they find that a huge percentage you can't see on the X-ray. So what does that mean for your practice? If you have a case where the patient's injured and you can't document it, what does it do to your case?
Yeah, it doesn't help.
Doesn't help.
Leaves with a hope.
Well,
Yep.
well put. It doesn't help. All right. So
Yeah.
documenting the injuries, is my job. I look at it a very agnostic. My job is to document the injuries so you can do your job, and obviously help the patient and help your legal case as well. Right. So moving right along, postmortem studies show that the spectrum of injuries can befall the spinal joints in motor vehicle accidents. Biomechanical studies of normal volunteers and cadavers reveal the mechanisms by which the spinal joints can sustain injury during whiplash. Whiplash studies in cadavers and laboratory animals have produced spinal joint injuries. Clinical studies have shown that the spinal joint pain is very common among patients with chronic neck pain after whiplash, and that this pain can be successfully eliminated by radiofrequency neurotomy. That's where they actually burn the nerve going to the joint. All right, conclusion. The fact that multiple lines of evidence using independent techniques consistently indicate the cervical spinal joints as a site of injury and a source of pain strongly implicates injuries to these joints as a common basis for chronic neck pain after whiplash. Dr. Bogduk also notes, convergent validity arises when multiple independent approaches point to the same conclusion, which allows for a greater confidence in the conclusion. In Whiplash, 4 convergent lines of evidence implicate the cervical spinal joints as a leading source of pain in patients with chronic whiplash-associated disorder. To prepare this paper, Dr. Bogdu only used original data on the topic from his personal library and by searching PubMed with the terms whiplash, neck pain, spinal joint and injury. Should we have the next article with that diagram?
Yeah.
I can get that diagram?
Yeah.
The postmortem studies identified a variety of non-lethal injuries. A, nerve root lesions. B, rim lesions to the intervertebral discs, where the disc is traumatically separated from the end plate of the vertebral body. Interarticular hemorrhages or bleeding. Fractures of the fractures of the facet articular cartilage. So that's the lining of the facet. So you got the 2 facets that line up and they're lined with cartilage. So when that joint impales the next one, that's where that cartilage gets damaged. Fractures of the facet subchondral bone and fractures of the entire facet articular process. Now here's the kicker. Virtually none of these lesions were seen on postmortem radiography. Medical imaging in vivo may fail to identify lesions that are definitely present at postmortem. Consequently, in the context of whiplash injury, normal radiographs or even normal MRIs do not mean the patient has no lesion. Human biomechanical studies identify these injurious mechanisms. The cervical spine undergoes a highly abnormal S-shaped deformation with extension of the lower cervical spine and flexion of the upper cervical spine. During the extension of the lower cervical spine, the anterior margins of the vertebral bodies are widely separated, resulting in avulsion of the annulus, fibrosis, and the vertebral end plate. All right, so we got our model here. Okay. So first, the joint opens up. All right, and you can see in the model here that there's a separation between the disc and the spinal bones. And let me there we go. Okay. All right, so we can see here, so this is the effect. All right, you get the joint opens up, the disc actually tears from the bone. All right. So medical imaging in life, all right, in vivo, may fail to identify lesions that are definitely present at postmortem. Consequently, in the context of whiplash injury, normal radiographs or even normal MRIs do not mean the patient has no injury. The human biomechanical studies identified these injurious mechanisms. The cervical spine undergoes a highly abnormal S-shaped deformation with the extension of the lower cervical spine and flexion of the upper cervical spine. Right? So this one's extension and that one's flexion. So this is a poor example of an S here, but you get the idea. All right, we have the top of the spine into the, hold on, let me see if we make sure I get it right. Extension of the lower cervical spine and flexion of the upper cervical spine. So the bottom opens up and the top closes down. During the extension of the lower cervical spine, the anterior margins of the vertebral bodies are widely separated, resulting in an avulsion of the annulus. Also during extension of the lower cervical spine, the inferior facet articular process chisels into the superior facet articular surface of the vertebral body below, allowing for the spectrum of lesions to the facet joints. The interarticular cartilage can be contused or ruptured, and impression fractures of the articular process could occur. Cadaver studies during whiplash show that facet joints undergo compression that exceeds normal physiological limits, and the capsule undergoes strains beyond normal limits. Strains in the annulus fibrosis can exceed normal limits. So we got a great diagram here. All right. So here, the front here, that's the lesion where the disc tears from the bone. Right here are your spinal joints in the back. All right, so you're showing a tear into the
Yeah.
cartilage. You're showing a fracture into the bone. Got it, Mayor?
I do. Nice picture. Yeah.
Yeah, so this is actually from next week's article. Another
Okay.
one with Dr. Bogduk. Good. All right, next page. So, whiplash overview summary. All right. When concerning whiplash injury, 3 questions are important. What are the primary tissues that are injured during a rear end collision whiplash trauma? Number 1 is the facet. Number 2 is the intervertebral disc. So in the cervical spine, I think we talked about a little bit about, it's about 60% facet, 30% disc. What is the tissue source of chronic whiplash pain? It's going to be your facet capsule primarily, and then also the intervertebral disc. And interestingly, what tissues are primarily affected by the chiropractic spinal adjustment? The facet capsule and the intervertebral disc. So this is why there are studies on chronic whiplash patients who fail to respond to traditional medical physical therapy management who respond exceedingly well to chiropractic spinal adjusting. So the best one was Woodward in 1996 and Kahn in 1999. Questions?
Big question is the fact that, doctor did a lot of his stuff and a lot of it was post-mortem examination and proof and such.
Well, not always. They used all different kinds.
Yeah.
They had 4 different kinds of studies here. But the post-mortem ones, I think, are the most valid, because you actually get to see with your own eyes what the problem is. You're not relying on imaging, which may or may not work all the time.
Yeah.
And the only problem with post-mortem studies is you gotta have a dead patient. Any other questions? No other questions? All right, then, since that was a quick one, I'm going to, did you see my article in the Matter Journal?
No.
Okay. So Jack sent out a copy of this last class there. We can send out another one if you like, but it was in the April 2017 Matter Journal. And it talked about, the title of the article is Raising Case Value of Soft Tissue Injury Cases. So I'll just read you the highlights here. So recently at the Mata holiday party, an attorney told me that one of his goals in 2017 was to raise his case value. As you've noticed, settlement values have been on a steadily downward trend for many years. Some of the decrease in claim value has been the result of insurers' bad faith efforts to make their customers' premiums an income stream for their corporate shareholders, and some of the decrease is related to the lack of documentation provided to attorneys by the healthcare industry. The high overhead of the medical practitioner, 100,000 plus malpractice premiums for a surgeon, coupled with ever-decreasing reimbursements, necessitates a high-volume practice, and too many critical details in the doctor's documentation are left out. According to James Mathis, a former claims senior supervisor and management specialist for both State Farm and Allstate, who instituted these claim processing reducing outcomes, there are 4 case value drivers. Number 1 is the injury. Number 2 is the impairment rating. Number 3 is duties under duress, which are activities you can do, but it hurts. And then we have functional activities, which you can no longer do. Now, the critical component to this is going to be your impairment rating, because the impairment rating unlocks the bottom 2, all right, the functional loss and the duties under duress. You only get, so you don't have the impairment rating, you're really behind the 8 ball as far as getting a decent settlement. All right, a critical component is the impairment rating. This is due to the fact that the impairment rating unlocks the value in the duties under duress and the functional loss categories. According to attorney Michael Schaefer in his class titled Demand Packages in Colossus, the impairment rating can unlock up to 75% of claim value. The key test that unlocks an impairment rating in soft tissue, ligament damage, is called computerized radiographic measuration analysis. This test is the best way to document ligament laxity. In my experience, up to 70% of your female and 50% of your male clients have this injury, and that it is not being documented. The technical name for ligament laxity and damage is alteration of motion segment integrity, also known as AOMSI. The AMA Guides to the Evaluation of Permanent Impairment, a 5th edition, page 378, describes AOMSI as either a loss of motion segment integrity, increased translation or angular motion, or decreased motion resulting from mainly from developmental changes of fusion, fracture healing, healing infection, or surgical fusion. So we have our model here. So there are 2 ways that they measure this AOMSI. One is how the vertebrae slip. All right, it's a little hard to do here. So let's do it on this guy. All right, the vertebrae can slip on one another. All right, so you see the bottom one has moved behind the front one. That's called translation, when the bone slips forward and back. Got that, Mare?
Yes.
Now, angular rotation is when the bones rotate. All right, so you take the x-ray into flexion and extension, and if it opens up more than 7 degrees, it's considered injured. Right? If it slides more than 3.5 millimeters, it's considered injured. Now, the reason you get this bigger impairment is because this is surgical indication for surgery. So if you look on websites like the Spine Center here in Tufts, probably, they will show you that say, you should come see us if you have more than 3.5 millimeters of slippage or 11 degrees of angular rotation. Right. All right, so page 379 of the AMA Guides describes how to determine its presence. Motion of the individual spinal segments cannot be determined by a physical examination, but is evaluated with flexion and extension x-rays. Loss of motion segment integrity is defined as anterior-posterior motion of one vertebrae over another. Loss of motion segment integrity is also defined as the difference in angular motion in the 2 adjacent motor segments. All right. More than 11 degrees angular rotation at any level is considered a maximum threshold. Practitioners who are trained in biomechanical failure as a routine course of examination take these x-rays immediately when the patient first arrives and again in 60 days. All right, I think we talked about this last time a little bit, how with some patients, they get a lot of muscle spasms, so you don't want to do your testing then because they're all in spasm. But if they're not, you can take it immediately. Okay. According to Schaefer, in his webinar on minor impact soft tissue injuries, insurance companies reserve $60,000 when they see a diagnosis of ligament laxity. The caveat is that you need to have a Colossus-ready demand package to create fair and equitable claim value. One attorney who I sent them this info put together a 2-page demand with very little description of the injury suffered by the client. Combined with the untrained adjuster and the computerized cost containment programs, this is a pathway to a lowball settlement offer. This is common with too many attorneys, and it's a process that can be reversed to realize fair value and equitable settlements. All right, so that's how you get get rid of some of those lowball offers you've been getting. Make sense?
Yes.
Good. All right, so next time we're going to talk about the next article by Dr. Bogduk, all right, including that nice diagram we showed you, and a nice little segue. I think it'll be a nice 3-segment segue between the last class, this class, and then the next one.